And we're live.
All right, so this is Senate Health and Welfare. We're back. It is still February 13th. And we are shifting gears to look at S28, coming back to get some testimony from folks on S28. On the act relating to access to legally protected healthcare services. And so we're going to begin with Devin Green from you can introduce yourself.
Thanks for having me, Devin Green, Vermont Association of Hospitals and Health Systems, and I'm happy to follow up with written testimony afterwards. And I would just say that we understand the purpose of this act or this piece of legislation, and we support the language in the first section around unfair and deceptive acts and practices and expanding that to all healthcare providers. I think that makes sense. Where we have a little bit of caution is section 3 and the unprofessional conduct piece. I think, it talks about healthcare providers providing information that's confusing. And I think that's very subjective word. It's a little too broad and could apply to a lot of healthcare conversations. So we're working with OPR on that piece. And then also we feel like the failing to actively monitor folks who are working with you is also a bit broad in how it's currently worded. And so we're also working with the Office of Professional Regulation and with the medical board to see if we can tighten up that language a little bit. The one thing that we'll add is we think this is a great opportunity to provide healthcare providers with greater privacy given these times. Right now, if someone makes a request, a Public Records Act request, they can get a licensee's phone number and email, and we would like to make an exemption for that piece so that folks are
Not their office, but their home.
I think it's it could be their office. It depends on what they list, but even they have an office address on there, which is the way for folks to communicate. We would just like to ensure that
Demonstrating in front of somebody's house.
right, or harassment through email or
Right. So you're working with OPR and then on the section 3 issue, the wording. You're also working with Board of Medical Practice. Are you working with Board of Medical Practice on the telehealth provision and all that they were concerned about?
No, I haven't talked to. Yeah. Okay. So Vermont Medical Society. Can
Okay,
speak to that.
we'll hear
We
their
haven't
testimony.
considered
I want
that
to make sure that we're getting all the problems sorted out,
Yeah.
and then we'll be able to move forward.
Okay.
That's good. No, thank you.
yet. Thank you.
So go ahead, Jessica Barnard is here. And I think what we'll do, is Planned Parenthood here?
It's via Zoom.
Huh?
Via Zoom.
Via Zoom, okay, so Jessica Barquist is here. All right, so, Jessica Barnard.
Good morning. Yes, Jessa Barnard with the Vermont Medical Society. Thank you for taking up S28. We think it's a really important piece of legislation. We really support the committee's work on it and hope it moves forward. For those newer to the committee, we worked very closely also on Acts 14 and 15 of 2023, the sort of initial shield laws protecting both patients and providers from legal tactics we increasingly see being used by other states to harass those who seek or provide what we in Vermont have defined as legally protected healthcare activity. And we think that elements of this bill fill some important gaps that we've learned of since the passage of those laws. And as we've seen, again, other acts from other states taking place. So we generally are in support of all of the bill with as to echo Devin's request for additional time to refine the language regarding unprofessional conduct. So I'll just go through, as we agree with Devin, we support section 1 around expanding consumer protection laws to state that advertising for healthcare services, whether or not there is a charge for such services, cannot be untrue or clearly designed to mislead the public. We think that that's an important clarification. We support that change. Section 2 clarifies that reports submitted by Vermont clinicians regarding fetal deaths are confidential, and we support that clarification. I will speak a little bit, so the bill's a little, there are elements on topics that are divided between different sections. So both section 3 and 5 address using adaptive questionnaires to provide medication abortion. So I'll speak to both of those sections. Section 3 is for physician MDs regulated by the Board of Medical Practice. Section 5 is in OPR statute for advanced practice registered nurses, APRNs. We support amending Vermont statute that would allow establishing a clinician-patient relationship via an adaptive questionnaire. Specific to medication abortion services, not for all services. Currently, state law prohibits any use of an adaptive questionnaire for establishing a relationship. However, evidence, and then I've linked to several articles, supports the safety and efficacy of using a fully remote asynchronous, meaning at 2 different times, one person enters the information, another person responds at different timing for prescribing abortion medication, that the outcomes are the same as in-person care. I've also linked to more information showing how sort of the protocols for how this takes place. So there is a very detailed online asynchronous consultation. It asks a number of questions, the same questions that would be asked if you're sitting in the office with a clinician or over a video or phone call. All of your medical history, any contraindications, any potential risks of an ectopic pregnancy. The physician receives that information, reviews the form, and can ask for follow-up information. And that's what makes it adaptive. So it's not just a static form where you would enter data and then, the medication is mailed to you. There has to be an opportunity to ask follow-up questions. We think that's very important. And there's another article I linked to that gives reasons patients may choose this approach: cost, privacy, stigma, convenience. And it is an accepted practice. There are several organizations that already provide abortion services this way, and there are Vermont physicians who would like to participate in that, but currently cannot. As I said, the Board of Medical Practice statute currently does not authorize this practice. There is, however, guidance from the Federation of State Medical Boards. This is not binding. It is just sort of suggested policy that kind of consults with all of the medical boards around the country that allows for asynchronous prescribing. It's also at least VMS's opinion that not allowing this practice could conflict with Vermont Shield laws, which prohibit boards from subjecting a healthcare provider to discipline based solely on the provider providing or assisting with reproductive healthcare services, and that there should not be a public entity. It's illegal for a public entity to prohibit a healthcare provider acting within their scope of practice from assisting in terminating a pregnancy. I do want to know, again, very important to Vermont Medical Society, state statute holds prescribers responsible for meeting the same standard of care, whether they're providing services via telemedicine or in person. So they would have to feel assured they have all the information to meet the same standard of care, whether they're meeting with the person in person, via a video, or via this using a questionnaire method. And Vermont statute already also requires patient consent for telehealth services. This would be at the patient's request. This would not be something that a prescriber would be asking a patient to do. So again, we think this provision is really important, and thank you for including it in the bill. We have heard from the Department of Health. I had just talked to them, I've lost track of time. It's been yesterday morning, 2 mornings ago, about this provision. They are, I have not heard back. They were going to be talking to the Board of Medical Practice and getting back to me. So I have not heard their latest position on this provision. But they did reach out to me. They did talk.
I don't know. This is a situation of people can be very stressed. Yeah. 16, I don't want my parents to know I have a congenital heart condition. I don't tell the doctor I have this problem. If I was in the office, he'd probably listen to my heart and, do a health screening and figure that out. So does the physician have to have my health records in front of him, or is this just an I ask you a few questions over the phone? Because my inclination, if I really needed this, and would be to tell him what he wants to hear. And that's what protects against that.
Yeah, I'm definitely happy. So again, this was sort of our initial testimony. Happy to have some physicians in who work in this model. I will say that they feel comfortable that they can ask the same questions that they would in person. A patient can lie, whether that's in person or online or on a questionnaire.
But if you're taking my blood pressure, I can't lie to you and say, oh, no, I don't have any problems.
So yeah, I think the question is there any physical examination that we're missing?
Yeah.
When, the abortion medication is prescribed?
I will say we already allow telehealth abortion services, which would not, so that already could be taking place, and that the data shows the outcomes are not different, that there are not more adverse outcomes or things being missed providing that service this way.
I just like,
But
because this is can be a highly emotionally charged situation. Or it's just going in for a regular exam or an earache. It doesn't have the kind of emotional impact that I'd love to not have to haul a kid up to the.
Yeah, and I can print out, or I linked to them, but I can send the full articles if you're interested. That this has been pretty extensively studied, especially really starting during COVID, doing what's basically hands off, no appointment, no exam, abortion services. So it's been a number of years now that these have been being provided, whether it's via, again, video visit or questionnaire, and there have not been serious, any concerns about it being different outcomes or different standard of care than an in-person visit.
I mean, it used to be you could call and say, my kid has an earache, and then send you out ampicillin.
Exactly.
Now you can't do that anymore. Yeah, and maybe now that they get paid for telephone calls, you can. But we want to make sure that we aren't.
They don't want to step outside of quality care.
Yeah.
Mhm. And that's why I think it's an important provision. We support it staying in state statute that you have to meet the standard of care. So if there's any information that flags any concern, you have to have further conversation.
Yeah, it's.
What, Senator Douglas, you have a question? No, okay.
So if you're ready, Section 8 addresses removing contact information from prescriptions, and we strongly support this as a privacy protection for prescribers. This is an option for prescribers to request that their facility name be listed on a prescription for medication. If it's being provided for reproductive healthcare services or gender affirming care. This is broader than, I want to be clear, just abortion services. So reproductive healthcare services includes contraception. It could include gender affirming care. The need for this sort of option arises from cases we are seeing being brought against prescribers being located in states with shield laws by states that don't. There's a prescriber in New York, for example, who's being sued by both or prosecuted by both Texas and Louisiana. I don't have all the facts, but presumably one method of doing this could be at the patient's house when they're investigating, they find the bottle with the prescriber's name and then know where they obtain the medication. Doesn't remove all risk, but at least it is an option to remove some of the identifying information from bottles that may cross state lines when it is fully legal within Vermont to obtain such medications, but may not be where that patient lives. And then some of this, so it's actually sections 3 through 7 and section 9 that have unprofessional conduct language for various professions, both under OPR and Board of Medical Practice professions. And Devin's already flagged it. I know Senator Douglas raised some questions in the walkthrough of the bill. We share the concerns about how broad some of the existing language is, and just we understand and support the concept of wanting to try to make sure that those delegating services are providing sufficient oversight. But we also want to make sure not to stop healthcare services in their tracks, especially there was some existing language around failing to review and approve information prior to communicating the information. And that this is on,
Like the last one.
it's repeated in
Correct.
a number, it is repeated in several
different
sections.
Professions, yeah.
But for the various professions, so it starts in section 3 is the first place it's referenced. Where that would, it could be read broadly to mean something like, the medical assistant brings you in the room and takes your blood pressure. Can they tell you what your blood pressure is before it's approved by the, the clinician who's your
They
ACP?
always do that.
Well, currently they do always do that, but could they do that if it's this language says reviewing and approving
They
information?
don't, it's usually when it's bad.
Right. Oh, okay. Right. Then they don't want to tell you, like they're not supposed to be providing diagnosis information. So in any case, we don't think that was really the intent of this language. We're happy to, and OPR has been very open to working with us. We've looped in the Board of Medical Practice. So we would appreciate if the committee would be open to us having a little additional time to kind of continue those conversations and reach a more focused approach to addressing the concern. We do have 2 additional recommendations for strengthening the bill. This one is the same that Devin mentioned around confidentiality protections for OPR licensees who have listed email addresses or phone numbers. The other is considering adding further protections on data sharing regarding legally protected healthcare activity. The SHIELD law you passed has very strong language around restricting data sharing if other states are bringing investigations or proceedings for the provision or receipt of legally protected healthcare activity. We would suggest actually a 2-word amendment from interstate to also or federal investigations or proceedings. Again, to the extent we can, we know there are limitations on how much some of this may hold up, but having some clarification that if it is a fishing expedition as opposed to a true audit about quality or something like that, that we would not simply turn over information. So thank you for considering that. I'm happy to continue to work on the bill with you, and thank you for taking it up.
Good. Yeah, no, please do work on it. It's helpful to get some of this settled outside the room and have folks come together. And we don't have your testimony.
Oh, sorry, I didn't.
We don't have either one. for the
Okay,
new-
I sent it late to Kiki.
That's okay.
Justice is on.
It's
Justice is
oh, I
on.
have to refresh.
It may just have been posted recently.
Because that's our calling.
All right. Good. Yep, I got it. No, I don't. got it. It's 28, right?
Mhm.
I don't have it yet. It'll show up. It'll show up, but
Well, thank you.
thank you for that. So you're working with OPR and the board, and it'll be helpful. And so good. We'll move on to Jessica Barquist and Deputy Commissioner Gray. We're going to take just a few more minutes on this bill, and we'll get to you. I appreciate your being here on short notice. Good morning.
Good morning. Hi, everyone. For the record, Jessica Barquist. I'm the Vice President of Public Affairs for Planned Parenthood of Northern New England. Happy to be with you all today, even though it's a snow day. So we haven't been in this committee yet this year, so I'm going to give you a little bit about who we are, and then I'll dive into the bill. And so Planned Parenthood of Northern New England provides comprehensive reproductive and sexual health care to more than 1,600 people in Vermont at our 7 health centers, as well as virtually through our telehealth program. People turn to us for affordable, high-quality care, including wellness exams, birth control, STI testing and treatment, cancer screenings, abortion care, vasectomies, as well as a variety of limited primary care services. We see everyone who comes to us regardless of their ability to pay, and 54% of our patients have low income. Last fiscal year, we provided 1.3 million in free and discounted care to our communities in Vermont, which is a significant increase from FY23 when we provided $802,000 of free care. So we broadly, strongly support S28 and think this is absolutely a really wonderful next step for Vermont. Thanks, Vermont. Thanks in large part to the bold and innovative work of this committee, was one of the very first in the nation to safeguard abortion and gender affirming care. And these protections are more essential than ever as attacks on reproductive and gender affirming healthcare escalate across our country. Vermont really stands as a beacon of hope, offering care, dignity, and safety to those forced to travel from states that criminalize these services. So we really see this bill as a crucial next step in ensuring that providers can continue delivering essential care without fear of legal threats or political interference. By strengthening these protections, Vermont reaffirms its commitment to healthcare access, bodily autonomy, and the fundamental right of all people to make their own medical decisions. Getting into the language of the bill in section 3, those updates to professional standards, you've heard some concerns about that language. I'm going to bring up a slightly different one. We have concerns with the language. It's on page 10, line 7, under section D, related to the failing to review and approve information about treatment or healthcare services. And we feel like the language in this piece is just a little ambiguous on whether it refers to information given to users or potential users, healthcare services provided to users, or services offered specifically by the entity or in general. And I think ideally we would want to say that licensed provider needs to review all of the medical health related information that is being given to users. And I have some language that I added in my written testimony for you, but really what we want is to make it clear that providers are responsible for all of the information provided to a user about healthcare services, whether or not that entity is providing those services. Moving on to the adaptive questionnaire, sections 3 and 5, you've already heard how critical this is, and we fully support it as written. Medication abortion is highly safe, and the questionnaires use best medical practice to effectively screen out individuals who may not be suitable candidates. And while we believe that it is included in the scope of the language termination of a pregnancy, it might be worth noting and specifying miscarriage management as well. So it would read to terminate an individual's pregnancy or for the treatment of a miscarriage, just so that there's no concern that could be included as well. Moving on to section 8, this is the confidentiality of prescriber information on prescription bottles. And this section is critically important to reproductive and gender affirming care providers in this state, including our PPNNEs healthcare providers. This is something that our healthcare delivery team asks me about almost every week to get an update on, because it's something they're very concerned about. And they are very excited that this committee is taking up this provision. I did share with you all a testimonial from a provider in my written testimony about just how critical and important this is. And for the sake of time, I won't read it all, but just know that providers are deeply grateful that this is happening. And we really applaud, we've seen other states do this, but we really applaud the committee for including gender affirming care in this provision. We wholeheartedly agree that this protection is critical in today's climate where trans rights and trans healthcare are under scrutiny and attack. One concern with adding gender affirming care that may arise and complicate this section is that the federal government has the ability to reclassify drugs. And for example, one of the hormones that's used in gender affirming care, testosterone, is classified as a Schedule III controlled substance. And all controlled substances are documented in the state's prescription drug monitoring system. So we would like to suggest to this committee that this provision could be expanded and enhanced to also provide patient confidentiality by prohibiting the recording of abortion or gender affirming care data within that prescription drug database. And this is language that has just recently passed in New York, and a few other states are looking at as well right now. So I've also added in what language that could look like for this section. And that was all I had for you. Thank you again for your continued efforts to protect Vermonters' access to legally protected healthcare, and for the really thoughtful ways in which you are ensuring Vermont's healthcare providers are protected for providing this essential legally protected healthcare.
Thank you very much. And we have all of your comments on our webpage. That's helpful. My suggestion is that while the Vermont Medical Society and the hospitals are coordinating with OPR and Board of Medical Practice, and you've made some suggestions that may influence their testimony, I would like to see a group effort so that we aren't coming back and having to go through several iterations of this. So I'm asking you folks to bring us your best thinking on this collectively. That would be helpful.
Absolutely happy to work with them.
Thank you. No, that's great. And I know this is a difficult difficult place to be, because it will continue to be a difficult place when government intrudes between the medical provider and the patient. And we're trying to avoid that as much as possible. So thank you for your work, all of you. And we're going, unless there's questions. Sorry, I didn't forget my committee one. Questions. So do we have questions at this point? Sounds like some of the questions that Senator Douglas was asking earlier are being discussed, and maybe we'll see some.
Possibly.
Yeah, see. Okay, thank you. We're going to move on to a different topic, because that's what we do in here. And I would just say for you folks who are here for the S-28, the sooner we can get language, the sooner we can start markup on the bill and make improvements going forward. Great, thank you. So the next topic is something that we have had testimony on. We talked about the General Assistance Housing Program. I think we're all aware of the issues that have been going on with trying to ensure that people have permanent housing. We've passed a lot of bills on housing. And the Department of Children and Families has been working on both general assistance and adverse weather programs. The Budget Adjustment Act includes language and money to extend services for people. So keeping people covered either through shelters or motels. And so I've invited Deputy Commissioner Gray in to share with us the Department of Children and Families perspective and what you're looking at. You can come up. Why don't you come up and one of the suggestion in the BAA is to extend coverage for people. It's really extending the adverse weather program, but doing it in a way that allows for staying in motels, hotels, or shelters, and keeping people covered from, instead of ending in April or March 31st, extending that to June 30th, or 30 days in June, yeah, June 30th, and having, and there's a dollar amount in the Budget Adjustment Act of $1.8 million for that. That's what's been covered. And the question, the Appropriations Committee is dealing with this, but the Appropriations Committee would like for us to consider what is being done and to weigh in on this discussion. So I'm going to turn it over to Deputy Commissioner Gray. I know that we've got, is it Megan here? Good. To help us. And then Brenda Siegel is here. She's been very much engaged in this whole process between House and now Senate. So first we want to hear from you, and then we'll spend a little time ourselves trying to sort out what feels good.
Sounds great. Thank you for having me. For the record, Miranda Gray, I'm the Deputy Commissioner of the Economic Services Division, and I have Financial Director for DCM Megan Smith with me as well. And just as Madam Chair said, proposal in the Budget Adjustment Act is to extend adverse weather conditions from ending from March 31st to June 30th. So an additional 3 months. What this means is that the 80-day limit that was passed in Act 113 would be waived. So those days would continue to not count, just as the December 1st to March 31st are not counting for individuals right now. Despite if they've used 80 days or haven't used 80 days, this time period doesn't count. And that would continue on until June 30th.
We're getting some. We have noise more songs going out. Thank you, Senator.
The hallways happen today, despite the weather out.
It's been a snow day.
Yeah, that's maybe what it is. What this also means is that the households who are currently in hotel rooms would more than likely continue to be able to stay in those hotel rooms, understanding that there's a lot of factors that go into the length of stay that someone has. But what that also means is that the 700 households who have not been able to access the GA program right now would continue more than likely to not have access to a hotel or motel room again until July. I think what this also means is, because that time period doesn't count, we would be looking at another big wave of people who would use their 80 days this summer potentially. And then so we would have a lot of people exiting again this fall, which brings us here, which does have a fiscal impact that is not reflected in the governor's rec right now, just because we hadn't anticipated this. And because there's a lot of factors, it's a range, but we're thinking that's about $600,000 to $1.9 million that should have an impact on state fiscal 26 budget. And then we're happy to go into the budget of what that impact is, as Madam Chair had said, to be able to extend until June 30th. But I think truly it is understanding that first, we have some people who chose to save some of their 80 days so that they would have that available to them this spring, who are not going to be able to avail themselves of that. And we know that we have households who use their time, and some of them are currently being housed in the GA program, and then others that are not. So I think it's just understanding that we are still going to be leaving some vulnerable Vermonters without shelter for a longer period of time to extend the cold weather. So I don't know, Megan, is there anything that you'd like to add from the fiscal standpoint?
No, I think you've covered it pretty well. Just that there's the need of 1.8 to cover the changes proposed in the House bill for 25, and then on top of that, the 600,000 to 1.9 million, which would be the sort of knock-on effect for 26 of having a larger population with more eligible days remaining as we go into the summer.
So, yeah, so I think it's important for us to understand here that the House Human Services Committee is working on a general assistance bill that may influence decisions made in the 2026 budget. And will have an effect on the motel program that we're all concerned about. Senator Cummings.
Now, I'm just trying to understand.
Yeah.
Last October, end of October, 1st of November, there was a caravan leaving the motel near my house. They'd run out of their 80 days. And there was big concern about the month of November. It got very cold. Some of our churches have been taking up collections and keeping people in the motel. I've talked with one gentleman who has an autistic son who got put in the family shelter. And the noise and confusion in the shelter, the child was regressing badly and threatening to run. So we got him into the church program. Then the winter went in. We had the motel adverse weather, which I think has been every day. And that was only for people who qualified or applied for general assistance. So if someone, so we're going to extend that program through July, which is good for those people. But if I had 30 days left on my 80-day limit, and I qualified for general assistance, and I get to July 1st, I'm going to lose that 30 days I had left on my, how do I lose days I haven't used?
So it's a rolling calendar year, so you won't necessarily,
It'll carry forward.
or I guess the kind of, it depends on when you started using your 80 days. And I'm sorry, this is one of the harder concepts. But so I don't know that you necessarily lose them. Because it's not like you don't get a restart unless you happen to start your 80 days last July 1st. Then you would be restarting in July. But for someone that had saved days, you would still have those days. It would just mean like, when did your 80 days end? And the new 80 days would start.
Okay, I'm just trying to figure out how many people we're going to put out. And there was apparently significant misunderstanding last time. I just from that, this was the joint, no, HROC, I think, health oversight. The testimony was the people that did the budget in the legislature understood that the commissioner had traditionally had just some ability to say, yeah, you know, you're 8.5 months pregnant, you've gone through your 80 days, we're not going to put you out. They thought that held. The legal opinion was that it didn't. And so we had situations where it was, you know, asserted that we were putting 85-year-old blind people out on the street, or women that were within 3 days of giving birth, who had given birth 2 days ago, out. I think I've heard in the hallway that that discretion is going to be reinstated and that it's not, so that when you finish your 80 days, even if you're 95 years old and blind, you are going to be out at least until the next. Okay, but but right now, everybody qualifies for general assistance. So I assume there might be some people who are working who won't qualify. But everybody that financially qualifies will be covered through July 1st. Then the new 80-day limit will kick in. But if you use up your 80 days, the risk right now is between that 80 days and when cold weather goes in next year. But there is legislation, and we have another budget coming in which it sounds like there's an intention to try and deal with that.
So, yes, yeah, you got it now. So, but I'm gonna,
Okay.
Senator Gulick has a question, and then I think I'm gonna ask Katie to come up and help clarify exactly what's in the BAA for us from our ledge council perspective, and then we'll get into conversation.
Thank you for being here. I picked up on something in your testimony just now, when you were speaking that you weren't anticipating this. And I'm wondering if you could clarify what it was that you didn't anticipate and why.
The extension of adverse weather conditions to go through June 30th. Because that isn't, I know that we have had other extensions in the past. I don't believe it was in June 30th. I think we had a May day, and I can't remember if it's the 15th or the 31st or the 1st. There was a day in May a couple of sessions ago, but that wasn't something we had anticipated that we've just passed Act 113, and that we would be carrying that forward, because at this point we haven't even had this law in place for a full year. So I think that is kind of
It was the whole 113 is the discussion that was had with appropriations, and with the House and the Senate, us, Human Services, Governor's Office, AHS, we're all in the room. So. Appropriations.
Because the BAA gets feed.
Still confusing, right? Got it. No, not confusing. Good. Okay. So I'm going to ask Katie to come up just to clarify what we're looking at in terms of the BAA. And then I think we'll hear from Brenda Siegel, and then we'll have a conversation. We have time to do all of that.
Hello. Katie McLean, Office of Legislative Counsel. Is it helpful to have a reminder of what is in the budget so you know what BAA is?
Yes, please.
So first I should just take a step back. I know we've talked about this once already, but I think it's probably worth repeating that general assistance emergency housing isn't a program that you're going to find in the green books. It's not codified. General assistance is, but the emergency housing piece is not. So every year, as part of the budget negotiation, general assistance emergency housing is negotiated. So it's a different package every year. So what you're looking at in budget adjustment is just the package for this fiscal year that ends June 30th of this year. And theoretically, a new package will be negotiated during this budget cycle, which would take effect July 1. So, you know, anticipating what that will look like, will it include limits on days? I don't know. Nobody knows yet.
Numbers, days.
We don't know what that looks like.
Access to
Depends
what?
on money.
Right, it depends on money, it depends on room availability, so that is why it changes from year to year. In terms of what was passed in the budget for this fiscal year, the first requirement is that if there is a shelter space available within the AHS district that the household presents itself, that is the first place that a household would be placed, and that the use of a hotel or motel room is only if there are no available shelter spaces in the district where the household presents itself. A few caveats there. So in the budget, there were room caps that were placed for 2 periods of the year. So the first period of the year was September 15th through November 30th. And during that time, 1,100, the program was capped at 1,100 available rooms. Similarly, the budget says that from April 1st to June 30th, there is that same room cap. Also, as you've heard Deputy Commissioner Gray talk about, there is also this 80-day limit, and the 80-day maximum is not applicable to the shelters. It's only to a hotel and motel room, and it is not applicable for the whole fiscal year. There's a time period during the cold weather months where It's kind of like there's a hold on the limits. So during the cold weather period, a household can stay in a hotel or motel room if a shelter is not available, and those nights do not count towards their 80 days. So what does the House budget adjustment proposal do? It makes two changes. First, that room cap of 1,100 rooms, it removes that for the remainder of the fiscal year. So right now, under the budget, it would be in place from April 1 until the end of the fiscal year. And under the proposal that the House sent over, that would be gone, no room cap. Although there is sort of a natural room cap in that there are only so many rooms available. And the Act does say to the extent rooms are available. So there is that sort of natural cap. Also, the House sent over an extension of the cold weather period. So that means they're extending it all the way to the end of the fiscal year, June 30th, which means that if the cold weather period is extended and there are the caps are, the room caps are on hold, not the room caps, I'm sorry, the maximum nights are on hold during the cold weather period, then that is extended through the end of the fiscal year. So in essence, there wouldn't be any accrual towards the 80-day room cap for the rest of the year. Did I confuse everyone or?
Say it again. Yeah, say, okay, it's good. Say it again.
Okay. So what the House did is they extended the cold weather period that was supposed to end or is currently set to end on March 31st. They extended it till the end of the fiscal year,
Which is.
June 30th.
Thank you.
And because the legislation is set up in a way that nobody is accruing time towards their 80-day maximum during the cold weather period, by extending it, you're kind of doing away with that
Say
80 days.
80 days for the rest of the fiscal year.
Negating the 80 days and instead it's everyone has access because it's a adverse weather program.
Yeah, so a household,
there's rooms available.
If there are rooms available and
Yes.
shelters available.
Our homeless population is increasing. And we've got some hotels that have actually gone back to renting to the public, which during COVID, they really couldn't.
Right.
So we've got a limit on rooms.
And there's a limit on the amount we spend on each room.
Can I just ask, is that true? Is the data bearing out that the numbers are going up?
That's what I've been told.
Yeah, we'll hear from, well, I think we'll ask Brenda that.
Okay.
Yeah. And we'll ask Deputy Commissioner Gray that question.
so to summarize.
Wait, this is really helpful.
Under this proposal from the House, a household that has already used up their 80 days this fiscal year could continue to use a hotel or motel when a shelter is not available. A family that has not used up their 80 days, they have used 50 days in the fall. That doesn't impact their ability to continue to use a hotel or motel if it's available, assuming there's no shelter space for the end of the fiscal year. So basically, puts a pin in the concept of an 80-day limit in a hotel or motel for the rest of the fiscal year.
And the cost for that is estimated to be about $1.8 million.
I believe it was around that, but
Yeah,
I am not
no,
your
I think
fiscal person.
yeah, so that's what is in the Budget Adjustment Act.
Okay.
Is that amount to cover those additional folks for that period of time.
And even with all of this, there's still 700 households that don't have access. Is that true?
I don't know the exact number, but there is a number of that. I'm seeing Deputy Commissioner Gray shake her head.
Yeah.
And it's probably variable, but it's 700 people who are still without a place. If we keep the adverse weather program in place, however, that would mean as shelters open up, people could access those shelters. There wouldn't be no 80-day, and there's nothing, they could go to the shelters. True.
Yes, and including people that were in motels would have to
Yeah,
access those shelters.
right. But because the language, I think, does, put a preference for shelter usage.
No, I'm just, does anybody in this have discretion? I'm thinking of the gentleman with the autistic son who really digresses. There are some people with putting them in a shelter. People with different mental conditions are detrimental to themselves and sometimes to their fellow residents of the shelter. Is there any discretion to make, somebody can make a decision, or is this first come, first serve?
That's a question for both Deputy Commissioner Gray and Katie, what is in the BAA language.
The rule, so it's not in the BAA language and it's not, I'm sorry.
Okay.
But you're right that there is, so in the rule, section 2652(01), it gives DCF the authority to issue a de facto variance.
Okay,
Um,
so there is some discretionary.
There is that is the discretion.
Okay,
I knew I remembered it from somewhere. I didn't know.
yeah, I had to just look at
yeah,
all of my notes going back to September.
What section is that? 2650,
2652
52,
01.
41,
01.
01.
and can we ask Commissioner Gray a question?
Yes,
Last year, there were issues with opening shelters because it got really cold in the end of October. And part of it was staffing. They didn't have staffing to open. We said we prefer shelters. We have a limited number of rooms. What's the situation with the shelters? Are more opening? Are some of them only have staffing through March and they're going to be closing? And I mean, what's the situation there?
Yeah, it's across the board. We'd have some shelters that are seasonal shelters that would be closing. And then we have some shelters who we are hoping to have come on. So that's the Office of Economic Opportunity has been working to try to get more year-round shelters. I think we're poised to look at continuing the Waterbury and Williston shelters, those family shelters, because those originally we had planned on having also close on April 1st. And if needed, although not highly accessed last year, standing up those temporary shelters that we did last spring as well. So that's something else that we could look at doing.
yeah, by pointing out that the Williston family shelters have been so effective, and kids are in school in April. And then they leave in June, so moving them during the school year is problematic.
May I edit what I said before?
Oh, good.
Or correct what I said before? So that 2652 01 is specific to individuals with a disability. So as required by the ADA and Vermont Fair Housing Public Accommodations Act, reasonable accommodations and modifications will be made to policies, practices, or procedures when necessary as determined by the commissioner or designee to provide equal access to programs, services, and activities, or when necessary to avoid discrimination on the basis of disability.
Pregnancy isn't a disability.
Yeah.
Can't.
This is great. And so I didn't have Katie scheduled to come in. We didn't have any of this scheduled to come in, but it was a request of the Appropriations Committee that we consider this, and I'm really glad that we're doing that. So Brenda, do you want to make a comment?
Yeah.
Because I know you have a lot of data, and if you could just do it succinctly.
Yes,
So this committee needs to just think about this a little bit.
Absolutely.
Yeah.
So just for the record, I'm Brenda Siegel. I'm the Executive Director of End Homelessness Vermont. When I come in for my real testimony, I will give you more details about what we do, but we have two departments, Office of Housing Advocate that does direct service and Office of Research and Advocacy, and a report will be coming out in a couple of weeks from our research, from our second phase of our research. And we have been working on this so a couple things that came up. I want to just flag, which is we're talking about the people who maybe can't be in shelters. So those individuals, those 80 days that were used were the only option they had because there were, as you heard, no reasonable accommodations were allowed to be made after those 80 days. And those individuals can't actually have access to a shelter because most of those shelters won't accept people with those levels of disabilities. So, so that's something that's really important. Not all the shelters, but most of them. Also, all the people that are in the hotels right now are considered the vulnerable population. Our experience at Homelessness Vermont is that we do have clients that have not been able to get back in since December 1st. However, those clients often have multiple factors, like they have a bunch of kids and 2 dogs and they won't leave the district and they have significant disability and their whole medical team is in that area. And those are the ones that we've had a really challenging time. But usually if people call every single day, they do eventually get back in. So I don't know if that 700 is a rolling number or they've been tracking one particular 700 families. But I'm assuming it's a rolling number of like how many has been turned away, not necessarily who hasn't gotten in the end. And then the other piece is that there's really, like I said, every population is vulnerable. And there was an extension last year till June 30th, and there was an extension the year before to May 30th and June 30th. It was a mixed group of individuals. And what we saw in the fall, so this is the part that I think is really important to consider, is some really horrifying catastrophic outcomes. And our own clients, we had 7 clients die in a single week, 4 of them in this district. We saw many of our clients end up having hypothermia. We had a client who was brutally raped and hospitalized. We had clients in wheelchairs who were pushed out of their wheelchairs and had their phones stamped on. We had really significant catastrophic negative outcomes. So no one is saying that this hotel program is the end all and be all. And I think the work that's being done in health and welfare and the department's work on this issue and everybody's work on this issue is incredibly important. But also we saw what happens when we actually unshelter people, and it was pretty horrifying. And I think it was very public. So a lot of people saw it. And unfortunately for our team and for the providers all across the state, we ended up shouldering that burden at costs that none of us could afford. My own organization has an incredibly small budget, and we spent $8,000 on tents and another $20,000 helping people stay sheltered who had those types of challenges. And we had, I know Good Samaritan Haven spent a significant amount of money, and we had people all over the state who did that. So it was not like the cost didn't happen. The cost was shifted, and it was pretty painful for our organization, but also in terms of our secondary trauma and moral injury, and very, very hard to get through. And I can say significantly it's calmed down since people have been able to be sheltered again. And if there was a large crisis happening outside of unsheltering, we would see it in our organization because we have a hotline.
Thank you.
Thank you.
Yeah, I mean, so it's a rock and a hard place. We understand that. We understand that the Department of Children and Families has been going through a very difficult time in developing rules, and the LCAR has been involved in the rules that do not match Act 113, last year's budget, and some believe that it's important to do what some members of DCF might want or other members might want. I think that for all of us, it's a human conflict. And what can we afford to do for the most vulnerable? And what does the hotel program bring us? Frankly, I see it as a transition to permanent housing, which we are also working on. So the question for us, and I want us to think about this. I'm not going to ask you to make a decision right now, but I am going to come to you and ask for a decision on your support for the $1.8 million or lack of that $1.8 million in the Budget Adjustment Act to extend the adverse weather program to allow for folks to remain sheltered until the end of the fiscal year, as the House is working on a GA bill. And we're going to be going through this again in the budget process. There's no question about it. But so I won't ask for your decision right now. You don't have time. If you have questions, for Katie or for Deputy Commissioner Gray or for Brenda Siegel at this point. Go ahead,
I
Senator.
have a question. The shelters, are they increasing security situations like what happened in Brattleboro, where that person in the shelter killed the other person?
So
Have they increased the security problems and the interviews with people beforehand, check their mental stabilities?
So from a provider perspective, I would say that that is why you have a lot of people with significant mental illness who are not able to access the shelters, and that the hotels do offer an option for those folks. I do think that there have been some protections put in place from that provider perspective as well, but we're looking at some really serious need for more support services for people with mental illness. And so that's what happened in there. But that highlights that congregate shelter, that putting up a big congregate shelter is actually really not a safe option, especially not hastily by you owners.
For certain people.
Yeah, it's for certain people, right? Yeah.
Any other questions? Senator Douglas, you good? Senator Goulart?
Yes, thank you.
Senator Cummings?
Yeah, I mean, I've got my
Oh,
answers.
thank you all.
I
And
but that's been going on for a while.
well, so no, let me just share with you,